So this is part 2 of exam 2 review and lecture, and we're going to go ahead and focus on, as promised, inflammation, infection, and cancer. There we go. Here we go. All right, so the inflammatory process. So when we think about the inflammatory process, we talk about, first of all, that first line of defense. And the first line of defense is really like your skin, right? So that skin is so important. We know about burn patients. When they lose their skin, the increase for infection is horrific. But when we break that barrier, the body has an amazing system in place called the inflammatory response. So we call that the second line of defense. So there's actually 4 cardinal signs is what we refer to. So what happens is you cut your finger. So the skin is now not there to protect you. And what we end up having is a vascular response. So some of that response is responsible for something called edema, which y'all know what that is, but it's swelling. So the arterioles near the site of the infection or injury, they really constrict very, very briefly, but then comes this vasodilation. That increases that blood flow to that injury site. And there's a reason for that, which I'm going to tell you about in just a minute. And so you're going to see that, there's some puffiness going on. Then you're going to start seeing that warmth and redness. A little bit of redness around a sore or a cut is really a good thing. You know that inflammatory process is working. So that increased blood flow and an increasing concentration of red blood cells at that site. So what ends up happening is there's a slower blood velocity, in other words, speed. So things are kind of getting housed around that break in the skin. And at the same time, there's an increase in blood flow at that site. So you see that warmth and redness. The other thing that's happening and why you're going to see some of that warmth, and this is going to also add a little bit to the edema, is leukocytes adhere to those vessel walls. Well, how do they even know to get there? Well, there's something called the chemotactic factor. So the chemotactic factor says, hey, come on down this way. And that's how they know instinctively to go head towards that cut or that sore. Now, pain, we've already talked about pain and these biochemical mediators, histamine, bradykinins, leukotrienes, and of course, those prostaglandins. Those help us realize that while there's something going on. In other words, we have a break in our skin, we've cut ourselves, fire, whatever. And so those are really the 4 cardinal signs of inflammation. So inflammation is really a good thing. So what else happens during this time? So something called phagocytosis. It really is the destruction of any microorganisms and even helps clean up some cellular debris that might be out there. But the first thing that has to happen is some sort of recognition. I mean, that's called opsonization. Opsonization is just a fancy word for saying recognition of the target. And so before that phagocytosis can even begin, it has to be able to recognize that there is something out there that they have to kind of eat up and take to those lysosomes, engulf it, and make sure that it is processed and destroyed. So opsonization, definitely that first very important step in this process. The next, of course, now you can see from this, so there's the opsonization up. It's recognized. Now it's going to start the phagocytosis, which is it's going to be engulfed, ingested, and it forms a phagosome. Next is that fusion with those lysosomes. Remember we talked about the lysosomes and what they do, kind of the trash can, cleans up debris in the cell. There we go. It's kind of that digestive system and helps turn those, it makes those lysosomal granules within that phagocyte, and it begins to destroy. And sure enough, that last step, it is destroyed and life goes on and no infection ensues. So the other part, and this can be a good thing or a bad thing, but it's called that systemic inflammation. So systemic inflammation, in this case, there can be an acute inflammatory response with a fever. And so leukocytosis, it's a transient increase in the levels of those circulating leukocytes. But a very early systemic response, once again, is that fever. So it's partially can be induced by specific cytokines. For example, interleukin 1, you don't really need to know interleukin 1, but you do need to understand that it's going to be released from those neutrophils and macrophages. So these fever-causing cytokines, they're known as endogenous pyrogens, and you need to understand that they're different from exogenous pyrogens. But the whole thing is, what do those pyrogens do? Well, they're going to go to the thermostat. And what's the thermostat of the body? The hypothalamus. And so it triggers that hypothalamus to increase the temperature of the body. So really, we found out that actually sometimes that's not a bad thing. A febrile response can actually be a good thing, particularly with certain types of organisms. And those types of organisms, for example, syphilis, gonococcal urethritis, those are very sensitive to higher temperatures and can actually help fight off. Of course, we still need the penicillin. But anyway, can at least maybe control that until further treatment is available. So next we're going to talk about immunity. So we talk about the different defenses. So when we move into this stage, we're really going into that, what we call that third defense. So the skin's broken. Okay, the second defense comes into play, inflammation. Hopefully that takes care of it, but if not, there's always what we call that immunity. So when you think about inflammation, it's very different in that when we think about inflammation, it's already pre-existing in the blood and tissues, and it's activated like immediately. Versus when you think about the humoral immunity, cellular immunity, this is much more specific. The inflammatory response is pretty similar to no matter what happens, any kind of tissue damage. It might vary a little bit, but when we're talking about the adaptive immune response, it is specific. These are the lymphocytes and the antibodies induced in response to a particular infectious agent. Pretty cool. Next, the residual mediators of inflammation, they have to be removed because if they remain in place, it'll start tearing down good, healthy tissue. So, for example, when we talked about apoptosis, neutrophils undergo apoptosis because if we leave them there, they're going to start causing damage to good cells, and that's what we don't want. However, with the immune response, the adaptive immune response, it's very long-lived, it's systematic, and the beauty of it is it has memory. So when it's exposed that first time, now the next time around, what's going to happen is, wow, it's going to have a really powerful defense against whatever potentially can be coming its way. So let's talk about the two different arms. Although you have to remember these two work very closely together. So humoral immunity, think antibodies. So antibodies, they circulate in the blood and it binds to the antigen on that infectious agent, all right? And then it's going to destroy it, the pathogen, and life is good. It does have memory, okay? Let's go to cellular immunity. Now think T cells. So T cells, they can undergo differentiation, of course, and so the immune response, they develop into some of these subpopulations. So T cells, they can stimulate the activities of other leukocytes, maybe with cell-to-cell contact. Other ones, they go into something called T cytotoxic cells. They attack and kill targets directly. So some of them function in a little bit different way, but you really want to think about T cells. The other thing that T cells can do, particularly these T cytotoxic cells, they go after those viruses. Also, cancer. They can help prevent and clean up any potential precancerous cells or even cancer cells. So when someone has a deficiency in these T cells, you're going to think potentially cancer and malignancy. So next, let's talk about active versus passive immunity. I really like this, what I've added to this PowerPoint. It really does a good job of going the difference between active, passive, when it's naturally acquired versus artificially acquired. And when we say artificially acquired, we're talking about vaccinations, right? So the adaptive immunity can be either active or passive, I just said that, depending on whether there's antibodies or T cells are produced by an individual in response to either an antigen or administered directly. So active acquired is produced by an individual either by a natural exposure, so such as a common cold. The problem with the common cold is it keeps mutating, and gosh, I don't know how many different viruses there are for the common cold, but let's say you get a cold, you'll never get that same kind of cold. Of course, you'll probably get another kind of cold, but that's an example of a natural exposure. But it's also through immunizations, such as pertussis and tetanus and that kind of thing. Passive is where it doesn't involve any of the host's immune response at all. It's passive. So a really great example of this is breast milk. And so the mother, through that breast milk, can provide that natural maternal antibodies, and the baby can actually be protected through that breast milk. So that's an example of a passive form of active immunity, of passive immunity. So these are the classes of the immunoglobulins. Immunoglobulins are just kind of a fancy word for their types of antibodies is what they are. So make sure that you know these. And the IgG, for example, it is the most abundant. We know that. The other thing about the IgG is that even though it's certainly the most, we always really think more about this with the transport of it across the placenta. And so it's really protective of that fetus and along with that newborn. IgA think secretions. So IgA, it's found in those bodily secretions like mucus. So I always think about the lungs. That's a really, it has a high level of IgA and very protective, and which is a good thing because when we breathe in, that kind of thing, and then of course the lungs help us expectorate that through sputum. So IgA think secretions. IgM though, this is huge. IgM is the largest of the immunoglobulins. If you go to your book and you look at a picture of it compared to those little IgA and IgG, this thing is humongous. But the thing about that is that we really refer to the IgM as it's that primary first responder. And it is synthesized very, very early in neonatal life. But it certainly can be extremely important, particularly as that first responder. And IgE, we're going to talk about here in just a minute when we talk about hypersensitivity reactions. And so we'll talk about that because it's special. Here we go. Next, first, we're right back at IgE. So IgE, it is associated with that type 1 hypersensitivity reaction. When we think about a hypersensitivity reaction, of course, there's 4 of them, but it's really an altered response to an antigen that results in disease or damage to the host. So it's gone rogue, in other words. And so with type 1 reactions, we know that it's mediated by, yes, IgE, and the products of tissue and mast cells. This is what, as a provider, your healthcare provider, we really talk about these as allergies. We know some of the most common allergies, pollens, nuts, And so hypersensitivity reactions, we think allergies and IgE. Type 2, on the other hand, now we're going into antibodies, right? So we think about antibodies, they bind to the antigen on that cell surface. So what ends up happening is with type 2 hypersensitivity reactions, they're generally characterized by a specific cell or tissue as the target. All right, so an antibody-dependent cell-mediated cytotoxicity, that's kind of a fancy word, string of words, it's a mechanism that involves such things as the natural killer cells. These are cytotoxic cells. And a really good example of this, we talked about Graves' disease way back in exam 1. It seems so long ago. But we talked about Graves' disease. We know it's an autoimmune disease, right? But how that works is really a type 2 hypersensitivity reaction. And it causes excessive thyroid activity. And what happens is those autoantibodies, they bind to and they activate that TSH, which is that thyroid stimulating hormone. That is in the pituitary, right? It's a pituitary hormone that really controls the production of thyroxine. Thyroxine is the hormone of the thyroid. So what ends up happening in this way, that antibody actually stimulates the thyroid cells to produce that thyroxine. So there's one example of a type 2 hypersensitivity reaction. Here's the second one. So really, when you look at this, and it's for you to have a good visual, but why is this a type 2? Well, because if you give the wrong blood to someone, that's what you're going to produce, is a type 2 hypersensitive reaction, which is not good because it causes the erythrocytes, they begin to agglutinate. And of course, agglutination and lysis causing a very, very dangerous reaction for these patients. So I've always used this to even teach students about transfusions, but the arrows, you can never go backwards. That's why that O blood, there's no antigens on that. That's why everybody can get O blood. But remember, can't go backwards. You got to keep moving forward. That's why someone with A blood, it has an anti-B, an antibody B. So you can't give that to someone with O blood. Same way with on the other side where you see the B blood. Now keep going forward. When you see AB blood, that's why they're the universal recipient. They don't have any antibodies, all right? But you can't go backwards. If you do go backwards, you give the wrong blood, you're going to cause that type 2 hypersensitivity reaction. So now let's talk about type 3. So type 3 hypersensitivity diseases are caused by an antigen-antibody immune complex, same thing as 1 and 2, but they're formed in the circulation and then deposited later in the vessel. Well, that's a problem because they can cause, and we're going to see Raynaud's phenomena. That's an example of what ends up happening, and I'll talk about that in just a second. So the primary difference between type 2 and type 3 is that with type 2, the antibody binds to the antigen on the cell surface, whereas in type 3, the antibody binds to some sort of soluble antigen. In other words, that can be released into the blood. Then it's deposited in tissues. And that's exactly what happens with Raynaud phenomenon. So a condition where it's actually temperature dependent. And so you might have heard this. It's called the white, blue, and red disease because at first there's pallor because it's lacking that circulation. Pretty soon no oxygen's getting into it, and so then it turns blue. Finally, once circulation is restored, then they come back with sort of a real red, ruddy color. So that's a great example of how those complexes get deposited within a tissue. And then, of course, the fourth one is is different. In this case, 1, 2, and 3, it really is mediated by antibodies, whereas type 4 is mediated by that T lymphocytes. They don't involve antibodies. So a clinical example of this is such as graft rejections or like contact dermatitis, such as poison ivy or some metals. But here's one example where a hypersensitivity reaction, remember I said in the beginning that this causes diseases and problems, but there's actually one clinical, actually a great clinical use, and that's when we do the PPD. So the PPD is actually a delayed response type 4. So it's that intradermal injection, and we screen for TB. So it's not all bad. You know, there's very few things that you know that's all or nothing because we take care of humans. So this is one of those cases where it's actually very, very useful in screening for a very deadly disease. So next we're going to talk about autoimmune and alloimmune diseases. It's kind of the same term. We're going to use the exemplar of systemic lupus. So lupus is one of those diseases. It's chronic. It is one of the most common that you're going to see in your practice, and can be very devastating. Honestly, I used to think about lupus and thinking, oh, it's just that butterfly rash across the nose. And then I started working in a medical ICU, and I really saw just how serious lupus can be. Thank goodness there's some really good medications out there now that can help with that progression, but this isn't pharm. You'll get that soon enough. But let's move on. So what happens is the deposit of those immune complexes, and they contain antibodies against DNA. Remember DNA, it is stored in that nucleus. It is protected at all costs. And here's a disease, an autoimmune disease that's going after it. So now you can really appreciate these incredible, horrible signs and symptoms that can happen with our patients with lupus. And one of the big things that happens is it's deposited in those renal tubules, and they can end up in full-blown end-stage renal disease. Look at some of these other things, arthritis. Look at that photosensitive rash. That's what I was talking about a little bit about that butterfly rash. But that's why teaching these patients, you know, that ultraviolet rays come from the sun. It is damaging not only to their skin, but it can also activate and cause some of that damage that we talk about with that antibodies against that DNA. So we really have to teach them to wear those big hats, stay out of the sun, and that's just one of the things that we're going to teach these patients. Next, of course, is some of the immunodeficiency disorders. We're not going to focus on the primary ones. They're so rare. What we want to focus on is on these secondary. What are these secondary causes of immune and inflammatory deficiencies? So some of these are metabolic diseases that we see quite a few of. Alcoholic cirrhosis, of course, they're going to have that secondary problems with immune deficiencies. But we just talked about lupus. There it is, SLE. It is an autoimmune disorder, and we know that it can cause that secondary decrease immunological functioning. Also environmental agents, ultraviolet light, ionizing radiation, chronic hypoxia, all these affect the patient's ability to fight infections. Also some of our own medical treatments that we do for patients, anesthesia. Of course, that's short-lived, but it's something that when you have a patient that comes back from surgery, you know what? That's why we got to wash our hands, right? Also splenectomy. So with splenectomy, we're going to cover that a little bit more when we get into the GI system, but it's important to understand that the spleen, it contains macrophages. Macrophages help what? Fight infection. And so it's really an important organ when we think about our immune system. So without it, we have to teach our patients to be very careful. Of course, everybody has to wash their hands, but in this case, we got to make sure they're getting that good nutrition. And the good thing about the body, it can adapt somewhat without the spleen, but they have to be aware. Stay away from those crowded areas when the flu's going around, things like that. So they have to be a little bit more precautious. So the infectious process, so now those something's going on, that those first three barriers, it hasn't worked. But let's talk about invasion. So invasion results in that direct confrontation. So for whatever happens, yes, the inflammatory process is working, or that immune system's kicked in, nothing else happens, rids the body of the pathogen. But what happens if it doesn't? Now we move to that next level, evasion. So evasion of those body's defenses. And what happens is those microorganisms can now get into the blood. It's something called septicemia, which you're probably all familiar with. So there's two types of toxins. Exotoxins, those are released by the bacteria. They're usually enzymes, and they can, of course, do some pretty bad damage. The other thing about exotoxins is they can also produce antibodies known as antitoxins. Well, antitoxins actually is the basis for some vaccines. So we use those exotoxins, and of course, they can be live or they're considered dead, whatever. But what I want you to think about and know is that these antitoxins produced by those exotoxins are actually used for vaccinations, tetanus, diphtheria, and pertussis. So kind of a neat thing. Who would ever have thought of that? It's just amazing. Endotoxins now, though, that's bad. Now we're going into the really bad stuff. This can cause septic shock. And so septic shock, we usually think about gram-negative. And actually, septic shock is one of the leading causes of death in intensive care units. So we know that once in the blood, those endotoxins cause the release of vasoactive peptides and cytokines. Now, those endotoxins also activate the coagulation cascade and can actually cause something called disseminated intravascular coagulation, DIC. Right now, you don't have to know all the patho of DIC. We're going to get that when we get into HEMOC later on, but know that it can cause DIC. But here's the other thing. The endotoxin also induces the release of tumor necrosis factor, TNA alpha, by the macrophages. What does that mean? Which means it can cause circulatory collapse. Acquired immunodeficiency syndrome. This is, of course, the most notable form of a secondary or acquired immune deficiency. It's caused by human immunodeficiency virus, HIV. We know that this depletes those cells, those TH cells. But the other thing is that what we do know, it is blood-borne. It is a blood-borne infection. And healthcare providers, we are at risk for this, particularly with needle sticks. And of course, there's so many mechanisms in place to protect us now from needle sticks, but it can still happen. The thing about the HIV virus is it's kind of a weak little guy. Very, very, so the chance of us when we get stuck is really only about 0.3% that we will contract it. However, we would still go through the prophylaxis. But you know, hepatitis B is scarier. It's got 30%. So when we get stuck by a needle. Have you ever had the gamma globulin for hepatitis B? I have, and it hurts. Very painful. So anyway, moving on. So the current accepted definition of AIDS, it really relies on, of course, the clinical symptoms of the patient and lab tests. So right now, it still holds true. The CDC, the diagnosis of AIDS is by a decreased CD4 T cell numbers below 200 cells per microliter. All right. Very good. Make sure you know that. So let's talk about stress. I promised you in part one that we would come back to this. And in fact, it's become so important in pathophysiology. And we've got such a much better understanding of how stress impacts and how it can lead to disease. But these are the actual 3 stages. Number 1, the alarm stage or reaction, in which the central nervous system, it is aroused and the body's defenses are begun to be mobilized, right? So a bear You're not really cognizant yet. It's that feeling where the hair on the back of your neck starts standing up. Then it moves into the second stage, which is called that stage of resistance or adaptation. So the first stage is just that idea that, whew, we got an alarm going off, not really deciding what we're going to do yet, but things are starting to mobilize. We've got that sympathetic nervous system going into play. Now comes the second stage. This is where you actually perceive and you're going to make a decision. All right? So you're getting ready to take exam 2, right? Sympathetic nervous system, your heart's starting to race, and now you're going to make that decision. Are you gonna run? Or are you gonna fight? And that's where you decide, I'm going to attack this exam. I'm going to take one question at a time because I can do this. Now, if it's a bear coming at you, I recommend running, okay? Now, here comes the third stage. So you've decided to fight. Everything's going good. You're nailing that exam. All right, it's over, done, life's good. Let's go to stage 3. Stage 3 is where it becomes that level of exhaustion and disease can ensue. What that means is that stress is continuous. It continues to pound away at the body. We are not built that way. We are built with that fight or flight, we resolve it. But when people are under undue stress for a long period of time, that's why we want to teach our patients as well as ourselves to care for yourself. Find those coping mechanisms, take that time out, whatever it takes. Because what ends up happening is when that's continuous stress, it's going to break down some of those compensatory mechanisms that we call homeostasis. Homeostasis is very important, right? So exhaustion marks the onset of some of those diseases. The last little thing here is, once again, that overall health of the individual has a huge impact on whether or not that person moves to that third stage. Nutrition is so important. And nutrition is one thing. Of course, we know how important sleep is. I talked about that in part 1. So sleep, some of those basic things, eating, sleeping, excellent way of controlling those bad effects of stress. Another thing is there's a physiologic reason for it. One thing is albumin. We know how important albumin is already with fluid balance, but it's also albumin hangs on to a lot of things. Remember, calcium and albumin go together? So does epinephrine. So albumin is also a transporter of a lot of things. We know protein is a great transporter. But when we think about the catecholamines, epinephrine, it hangs on to albumin too. So albumin is a transporter. And without enough of it, how is the body going to help compensate with that epinephrine? Next, cortisol. I've already talked about this, I know, in part 1 related to deprivation of sleep, but I also want to talk just a little bit more as it relates to that stress response. So really, cortisol isn't all bad. It's that excessive cortisol that makes it bad. So cortisol secretion during that stress exerts really some beneficial. It inhibits that initial inflammatory effect. It also causes vasodilation and increased capillary permeability. So that's kind of a good thing. But it also suppresses T helper cells. And it decreases that pro-inflammatory response. So remember, pathology, I think you're already capturing the idea. You know, in any disease entity, usually it's something that isn't turned off and is continually being produced, or it's not being turned on. In addition, or it's being produced in excess or not enough. So in this case, too much cortisol is not a good thing. But really, I've got to give it some credit. It really promotes resolution and repair. So it really is good for wound healing. So like I said, cortisol isn't all bad. It's just when there's too much. Next, we're going to talk about cancer. Now, this is very broad overview of cancer. And so this is just a really nice chart. And what you need to know, what's the difference between benign versus malignant? When we get into the systems, particularly, like for example, when we get into the pulmonary system, we're going to go in more depth about lung cancer. But this is just a very nice overview. So when you think about benign, very well differentiated, malignant, no. Those cells take on their own little characteristics. Benign is very slow. Of course, malignant is very rapid. And that's because of that mitotic index. In other words, the ability of the cell to split and duplicate and grow. Very low in benign, extremely fast with malignant. The capsule. Benign, a nice pretty capsule. It's all together and underneath and very well protected. Versus malignant, there's no capsule there. Sometimes you hear oncologists call them fingers. So they have little fingers and they grab onto the tissue. And so makes it a little bit harder to remove. Vascularization, a little bit of slight with the benign because they do have to have that blood supply to continue to grow, even if it is slowly. But look at the malignant. This is just bizarre. Neovascularization, neo means new. They have the capability of making their own vascular system. Kind of scary stuff. Mode of growth, expansile versus malignant, invasive. You know, when we talked about that metastasis, which is the next thing. Yes, absolutely. Malignant can be metastasized. So the staging system, I just want you to know TNM. And if you would see this on an exam, you might see something like T2. All right? Well, okay, so you know there's a pretty good sized tumor. N, nodes. So if you would see T3N0, 0 means, oh, it didn't go to the nodes. And then M is for metastasis. So if you see T3N0, M0, or sometimes you'll hear O, but it's really 0, you'll say, wow, okay, so the tumor, it's not spread to the nodes and it's not metastasized. That's what you need to know. And next is about the blood test for cancer. So you'll have your patients come in and ask you about, I need a blood test for cancer. And there actually are some with all the wonderful research that's being done now. And some of these, they're hormones, they're enzymes, they can be genes, antigens, antibodies, you name it. But what's very interesting is, for example, PSA. That's been somewhat controversial, and of course there's guidelines on when we test for PSA for our patients. But the other good thing about PSA, it's a wonderful determinant of, is the treatment being successful. So if the PSA level goes down, you know that chemotherapeutics is working, or the radiation or whatever. So sometimes they're great for diagnosis and screening, but they can also be used for how well is the treatment working. Lastly, I want to talk about a tumor marker itself that has biological activity. So a great example of this, it's actually called paraneoplastic syndrome. And this is when the adrenal medulla, which normally secretes catecholamines, epinephrine, but a benign tumor can sit on top of that adrenal medulla. It's called pheochromocytoma. It actually can produce catecholamines, epinephrine, right? So these patients, they'll come into the ED emergency room and they'll come in with a really rapid pulse, extremely high blood pressure, and it's fascinating because it is a tumor marker, but it's physiologically active. All right, thank you. As always, reach out if you have any questions, and the live chat will be coming soon.